Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we will talk about the tumors of the middle ear. So let's start today's discussion. You are requested to like and subscribe the channel so that you are not going to miss any succeeding videos. Tumors of the middle ear, as anywhere else, these are also divided into two main groups, that is benign and malignant. And as you know that benign, these includes papilloma, lipoma, adenoma, schwannoma, endolymphatic sac tumor, and last but not the least is the glomus tumors. And then malignant group includes, of course, the carcinoma, and then there are different types of sarcomas like fibrosarcoma, osteosarcoma, etc. to complete the list. Overall, the most common tumor is this carcinoma. And if someone asks you about which one is the most common benign tumor of the middle ear, then the answer is glomus tumor, about which we will talk about in detail today. In addition to these primary tumors, there can be secondary tumors, means they can come from the adjacent areas like the nasopharynx, external auditory canal, and even the parotid tumors can spread up to the middle ear. And then there can be metastatic carcinoma in the middle ear. These metastases can come from carcinoma of bronchus, breast, kidney, thyroid, prostate, and even gastrointestinal tumors. So this is theoretically a list of the tumors: primary, secondary, and metastatic. The tumor which we will talk about in detail is the most common benign tumor of the middle ear, that is the glomus tumor. These glomus tumors are chemodectomas, or these are also called as non-chromaffin paragangliomas, which arises from the glomus bodies along the parasympathetic nerves, which are present not only in the skull base but in the thorax and in the neck as well. So the tumor, if it is arising from the promontory, then in the middle ear, then we call it as glomus tympanicum, and from there it can expand and perforate the tympanic membrane and can present as a polyp in the external auditory canal. If it is arising from the adventitia of the jugular bulb, then we can call it as glomus jugulare. It can arise in the neck from the vagus nerve and extend towards the jugular foramen, then we call it as glomus vagale. It can also arise from the carotid body tumors from the carotid bulb, there we call it as carotid body tumors. Synonymously, different names are used like chemodectoma, paraganglioma, ganglia tympanica, vascular tumor of the middle ear, but still the most common one is the glomus tumor. This is the most common benign tumor. So when it is benign, naturally it is slowly growing, but it is a vascular tumor. It is named because of its origin from the glomus bodies, which are found over the jugular bulb and the promontory. They also contains paraganglionic cells, which are derived from the neural crest. What are these paraganglia? These resemble the carotid bodies, and the middle ear paraganglia, they are distributed over the promontory along the branches of the tympanic branch of the glossopharyngeal nerve and the auricular branch of the vagus nerve. They are also present over the adventitious layer of the jugular bulb, that is the dome of a jugular bulb, and if this arises from there, then we call it as glomus jugulare. Histologically, they have got two types of cells. Type 1 is also known as chief cells or granular cells, which release the catecholamines, and type 2 are sporting or sustentacular cells. Valentine was the first one in 1840. There he used the term ganglia tympanica, while in 1902 the glomus jugulare was the term coined in 1924. Mason, he described it, glomus tumors, as hyperplastic glomus bodies, and in 1945 Rosenwasser was the first to diagnose a patient with glomus tumor and then its surgical excision. One in 100,000 population, its epidemiology, it is 5 times more common in females, autosomal dominant inheritance, located on chromosome number 11q23, mostly in 5th decades of the life, and commonly affected ear is left ear. Hypervascular tumor arising from the glomus bodies. These are found on, as we just mentioned, over the jugular bulb, glossopharyngeal and vagus nerve, tympanic canaliculus, retrofacial ear cells, promontory, geniculate ganglion, and they secrete not only the catecholamines but also the dopamine and serotonin, and few cases may undergo malignancy and then metastasis. So non-encapsulated, extremely vascular, benign tumor, slowly growing, locally invasive, and microscopically, there are masses or sheets of epithelial cells with large nuclei, granular cytoplasm, and there are thin-walled blood sinusoids with no contractile muscle coat. So when there is no contractile muscle coat, it causes profuse bleeding spontaneously or when being touched. Glomus jugulaire, it arises from the dome of jugular bulb. It can invade the hypotympanum and jugular foramen, and 9th to 11th, 12th cranial nerves can be involved, and it can compress the jugular vein and invade its lumen. While glomus tympanicum, it arises from the promontory. It causes the oral symptoms more and even can cause facial paralysis. So benign, encapsulated, slowly growing, hypervascular, locally invasive tumor. It expands within the temporal bone via the pathways of least resistance, that is the air cells, like mastoid air cells, vascular lumens, skull base foramina, and even the eustachian tube. Initially erodes in the region of jugular fossa and posto-inferior part of the petrous bone, and then there can be intracranial and extracranial extension as well, and very few can undergo metastatic malignancy, so they can metastasize in 4% of the cases to lung, lymph nodes, liver, vertebrae, ribs and spleen, but astonishingly the middle ear ossicles are usually spared. Macroscopically deep red firm mass that bleeds profusely on touch. Microscopically, the clusters of the chief cells, they are arranged in nested pattern called Zellballen, enclosed by fibrous stroma with rich vascular plexus. Gilt classified the glomus tumors into 2 types histologically: cellular glomus and vascular glomus. So glomus tympanicum and glomus jugulaire, according to the site of their origin. Spread initially, of course, they will fill the middle ear, later perforate through the tympanic membrane and can present as a vascular polyp in the external auditory canal. It may invade medially the labyrinth, then petrous pyramid, posteriorly the mastoid, below jugular foramen and base of skull, causing the last 4 cranial nerve palsy. It may spread through the eustachian tube and may present in the nasopharynx. It can go intracranially to involve the posterior and middle cranial fossae. 4% of the cases very rarely can metastasize to the lungs and bones or to the lymph nodes. When tumor is intratympanic, conductive type of hearing loss and pulsatile tinnitus. This pulsatile tinnitus is abolished if carotid artery is being pressed. On otoscopy, there will be red reflex, rising sun appearance behind an intact tympanic membrane which is bulging. If ear canal pressure is raised with Siegel's speculum, first the tumor will pulsate and then it blanches. This is called as Brownie's sign, and it is a blanching of the mass with manual compression of the ipsilateral carotid artery. That's what we call as Acuno sign. When tumor presents as a polyp in the external auditory canal, there will be history of profuse bleeding from the ear, either spontaneously or if the patient attempts to clear it. Then dizziness, vertigo if labyrinth is involved, facial paralysis, earache and atoria. There can be audible bruit which is heard by the stethoscope over the mastoid in all stages. When the cranial nerves are involved, according to the involvement of the cranial nerves, especially the last 4 cranial nerves, then there will be, of course, the dysphagia, hoarseness, then there will be unilateral paralysis of soft palate, pharynx, vocal cord, with weakness of the trapezius and sternomastoid on that side when 11th is involved, and the tongue muscles when 12th is involved. There can be a mass over the mastoid or in the nasopharynx if it has spread through the eustachian tube up to the nasopharynx. Signs of intracranial involvement with headache and projectile vomiting, and audible systolic bruit is there. Because these tumors, they can secrete the catecholamines, so they can produce the symptoms like headache, sweating, palpitation, hypertension, and anxiety. There is a rule of 10 for these glomus tumors. In 10% of the patients, they are multicentric, because as we know that glomus bodies are present in the body, not only the skull base but in the neck, and so the 10% of the cases they are multicentric. In 10% of the cases there will be family history of glomus bodies, and in 10% of the patients, as they secrete the catecholamines, so there may be patients may be hypertensive, and these are called as functional tumors. There are different classifications: Lundgren classification, GLASSCOCK, Jackson classification, Fish classification, Guild histological classification, and modified de la Cruz classification. This Lundgren classification is very simple according to the site of origin. When it is from the promontory, we call it as glomus tympanicum, and when it is arising from the dome of the jugular vein, then we call it as glomus jugulare. So this is the simple one. GLASSCOCK Jackson classification is: type 1 is the small tumor limited to the promontory. Type 2, tumor is completely filling the middle ear cavity. Type 3 is tumor is filling not only the middle ear but extending into the mastoid process. And type 4 is when the tumor has gone through the tympanic membrane to fill the external auditory canal or has extended anterior to the internal carotid artery. As far as glomus jugulare is concerned, GLASSCOCK Jackson classification for glomus jugulare is small tumor involving the jugular bulb, middle ear and mastoid. Type 2 is it is under the internal auditory canal. There may be intracranial extension. Type 3, tumor extending to the petrous apex, may be intracranial extension as well. And type 4 is when it is extending beyond the petrous apex into the clivus and infratemporal fossa, and there may be intracranial extension. So this is for glomus jugulare. This is modified de la Cruz classification, and the surgical approach according to the classification, it is mentioned there. This is the most commonly accepted or most commonly used classification for glomus tumors, that is Fish classification, in which type A tumor is limited to the middle ear, and of course it will carry the best prognosis. Type B is when tumor is limited to the tympanomastoid area with no infralabyrinthine compartment involvement. Type C is that involving the infralabyrinthine compartment. Type C1 will be with limited involvement of the vertical portion of the carotid canal. Type C2 is when invading the vertical portion of the carotid canal, and type C3 is when horizontal portion of the carotid canal is being invaded by the tumor. Type D is the tumor with intracranial extension, subdivided into type D1 with an intracranial extension less than 2 cm, and type D2 is when intracranial extension is greater than 2 cm in diameter. Differential diagnosis is with the otitis media, especially with the otitis media if it is having an oral polyp as well, autosclerosis, cholesterol granuloma, aberrant intrapetrous internal carotid artery, idiopathic hemotympanum, aneurysm, arteriovenous malformation, prominent jugular bulb, and persistent stapedial artery. Spread is, if it perforates the tympanic membrane, it will present as a polyp. If it invades the mastoid, labyrinth, and petrous pyramid, it can invade the jugular foramen and base of skull. So last 4 cranial nerve palsy will be there. Through the Eustachian tube, it can approach the nasopharynx, intracranially spread to involve the posterior and middle cranial fossa, and very rarely, in less than 4% of the cases where it goes to the malignant change, metastasis can occur to the lungs and bones and even to the regional lymph nodes. Pure tone audiometry, it will show us initially the conductive type of hearing loss, and later on, if labyrinth is involved, then there can be sensory neural hearing loss. On CT scan of the head with bony window 1 mm slice, there will be Phelps sign, which is obliteration of the keratojugular spine. Gadolinium enhanced MRI will show us multiple vascular flow voids as presented as salt and pepper pattern. If we go for 4 vessel angiography, the commonest feeding vessel will be inferior tympanic branch of the ascending pharyngeal artery. 4 vessel angiography will involve 2 vertebral arteries and 2 basilar arteries. Radionuclide scintigraphy will show us multifocal paragangliomas. Then these tumors can secrete catecholamines in 10% of the cases. So we can go for serum catecholamine levels and 24-hour urine for catecholamine, metanephrine, and vanillyl mandelic acid, that is VMA. Treatment is surgical removal. Radiation is only for those which are inoperable, and preoperative embolization will help us to reduce the bleeding while excising the tumor. Laser assisted excision will be more helpful, or a combination of these techniques can be used. So treatment of choice is microsurgical total tumor removal, and it should be preceded by preoperative embolization of the feeding vessel. And in advanced cases, when surgery not possible, we can think about radiation, though this is a benign tumor, so very little chance for radiation. So surgery will depend upon, according to the Fish classification, the type A and type B transmastoid approach, and in type C and D we have to go for lateral skull base approach. Preoperative embolization within 48 hours can reduce the intraoperative bleeding. Radiotherapy and chemotherapy for unresectable advanced tumors, and laser assisted excision gives good results. Role of radiotherapy for a benign tumor is always controversial, so same is the case here. And this radiotherapy will cause fibrosis of the arterioles rather than direct effect on the tumor cells. Stereotactic radiotherapy achieves better tumor control, and contraindication for radiotherapy is intracranial extension. Surgical approaches will depend upon the extent of the tumor according to the classification. So transcanal approach, if it is very small and whole circumference is available of glomus tympanicum, through the external auditory canal we can go, or we can go for hypotympanic approach, extended facial recess, mastoid neck approach, infratemporal fossa approach, and transcondylar approach. So these are the different approaches according to the extent of the tumor. So this is the transcanal approach. Tympanomastoid, this tympanomeatal flap is raised, and then inside the middle ear cavity the glomus tympanicum is seen and it can be removed. Extended facial recess approach is through the mastoid region. Here we can go. This is the facial nerve. You can see this one is the facial nerve. This is the facial recess through which we will approach it, and then we can see the tumor behind the facial nerve, which can be removed. This is mastoid neck approach. Here the tumor is fully exposed now, can be removed. So if there is no MRI or no interventional radiologist or operating microscope and no light source, then better to refer the case to the higher centers where expertise and facilities are available. As far as carcinoma of the middle ear and mastoid is concerned, it is a rare condition overall. Age group is 40 to 60 years, more common in females. 75% of the cases will present with ear discharge which may be blood stained. There may be chronic irritation from some causative factor and radical mastoid cavities. Already in operated cases, they are more prone to, and primary carcinoma of the mastoid ear cells can also be there, usually seen in those people who work in or who are radium dial painters. Spread can involve, of course, the ossicles, facial canal, internal ear, jugular bulb, carotid canal, deep bony meatus, mastoid, petrous apex, and dura is usually resistant. Other structures like parotid gland, temporomandibular joint, infratemporal fossa, eustachian tube, and then into the nasopharynx. Lymph node enlargement occurs very late in advanced cases. So, like chronic suppurative otitis media, it will present with discharge and hearing loss. But in 40 to 60 years of female patients, one should be suspicious of a chronic foul-smelling discharge, which is blood-stained, which is causing earache, which is very severe and comes at night more, along with facial palsy, and granulations or polyp. If it is there, it is friable and hemorrhagic, and vertigo can be there. But definitive diagnosis can only be made on biopsy. According to the extent of the disease, how we can appreciate that clinically, first will be with cranial nerve palsies. That will show us the extent of the tumor, and then radiological examination, which will include, of course, the CT scan, the temporal bone, and angiography is also useful in the assessment. And the treatment is surgery or radiotherapy or a combination of two. Then other tumors, just to complete the list, as I told you, different types of sarcomas can occur, so theoretically, otherwise very rare: rhabdomyosarcoma, osteosarcoma, then lymphoma, fibrosarcoma, chondrosarcoma, and distant metastasis can be to the lungs and to the bones. Thank you very much for watching. Please subscribe the channel and share it with your friends. Thank you very much.